Hello, everyone. Welcome to our new session entitled Testing Modalities for COVID-19 with the collaboration of Baylor St. Luke Medical Center. We are happy to interview today Dr. Maria Rodriguez-Barradas, Professor of Medicine, Infectious Diseases at Baylor College of Medicine and Chief of Infectious Diseases Section at the Michael Debacki Veterans Affairs Medical Center. Dr. Rodriguez graduated from medical school at the Center University of Venezuela. Then she moved to Houston for her infectious diseases fellowship at Baylor College of Medicine. Her research interests include pneumococcal disease and HIV, and recently the impact of COVID-19 in the veteran population. Welcome, Dr. Rodriguez. We are very glad to have you with us today.
Thank you very much for the invitation. I'm happy to be here and answer your questions.
Yes. So my first question, Doctor, we know now, we now have a lot of information about COVID-19, the virus that started back in December 2019. Can you brief us about the virus again? And is there any recent findings that we don't know about, that we discovered lately about the virus?
Okay. Well, as I think we all know by now, COVID-19 is caused by one type of coronavirus, the SARS coronavirus 2. It is one of 7 coronaviruses that infect humans. 4 of the other coronaviruses were identified first in the 1960s, and they circulate in the human community in the last several years. They usually circulate during the respiratory viral seasons. The other 2 are the first SARS identified in 2004 and MERS identified in 2012 that cause severe disease. I think the things we have learned are, one, we are more aware of how much asymptomatic disease we have with COVID-19. Up to 40% of the people who are infected are asymptomatic. We know now that most of the virus is shed at the beginning of the infection, and even people that develop symptoms can start shedding the virus 2 or 3 days before they become symptomatic. The other thing we have known, these viruses tend to mutate, but this virus, although it has mutated since it was first introduced in December, it basically has remained stable from the immunity standpoint, meaning vaccines that can be developed are likely to work even though the virus has mutated a little bit since it has first introduced. The important thing or the relevant things about the mutations is that they allow us to look at the epidemiology and see how one particular virus transmits and disseminates in the different populations. So we can tell that the New York virus, when it was introduced, came from Europe. The other viruses came from the one that was circulated in China, etc. So the epidemiology can be tracked that way.
Okay, so what I understand, it's mutating, but it's not becoming more dangerous.
It's not becoming more dangerous.
Okay. So
that we know.
Okay. No, now that the lockdowns are over in most countries and we are now starting to open up, testing and tracking are key in the fight against the virus. First of all, can you tell us why testing and tracking are very important in this matter? And what are the available testings in the market?
Yeah, testing and tracking are very important because that's the only way of detecting infected people, isolating them, and avoiding them to transmit it further in the community. With COVID-19, with the coronavirus SARS-2, the whole population is susceptible. So once introduced, everybody is at risk of acquiring it. And although we know 40% can be asymptomatic and a minority get very ill, because everybody is susceptible, the amount of illness and fatalities that will result if everybody gets infected is very large. So we need to, the best we can, isolate the people that are infected. It's just for 14 days while they're sick, and avoid transmission in the rest of the community and protect those who are more vulnerable. So by frequent testing, especially of those that get exposed, we can curtail the transmission within the community. That's the only way of doing it at this time, short of having a vaccine.
And what are the available testings in the market now?
Okay, we have two different tests. We have tests that detect viral particles, those are the viral tests, and we have tests that detect antibody responses. For the viral particles, we have two different tests. We have tests that detect the genetic material and tests that detect what we call antigen, which are the proteins in the surface of the antigen. Each has advantages and disadvantages. The genetic material, the ones that detect genetic material are far more exact or accurate. They're more sensitive, so they can detect lower levels of the virus in the samples, usually than theirs. On the other hand, they have to be run in more specialized settings, in laboratories, in hospitals, or other commercially available commercial laboratories. The antigen tests have the advantage that they require less sophisticated devices or instruments. Some have been developed to be done even at home in little carts, similar to a pregnancy tests, for example. They tend to be less accurate. So they can give more false positive results, meaning be positive when the person is uninfected, as well as false negative. Give a negative result when the person actually has the infection. So what you gain in being practical and making it more accessible, you lose in accuracy of the test.
Okay.
Antibody tests are not really recommended at this time for diagnosis. For similar reason, they have problems. If you're going to do it, it has to be later in the disease after 14 days because antibodies do not appear at least until week 2 after onset of illness. And they also have their own problems because not everybody has the same levels of antibodies. They can come down quick and you cannot detect them. So they give not, for the particular person, may not give accurate information. However, they can be very important when examining populations to see how much disease there has been in a specific population or community.
So, and what is the difference between diagnostic testing and screening testing for the SARS-CoV-2?
Yeah, diagnostic testing is when we use it to actually detect infection in people that we think have the illness or in people that have been exposed, for example. Screening is when you use it in a more widespread way to lots of people regardless of symptoms or exposures. For example, right now in the basketball championship here in the United States, everybody gets tested. Doesn't matter where you're coming from, where you have, every day you will get a test.
Okay.
In schools, some people promote for starting school, all children get tested before they get started. Kids that went to summer camp, everybody got this test. So when you use just mass testing, that's called screening. For example, here in my hospital, we did screening in residents from the nursing home. So all 200 residents in the nursing home got tested. That's screening, regardless of exposure of symptoms. All the nurses and providers, physicians that work in the nursing home, all got tested at once. That's screening. Regardless of presentation, you will be tested to see if we detect any positive asymptomatic person.
Okay, and
That's a basic difference.
Okay, and what will be the level of accuracy in testing, or what is the percentage of false results in these tests? Screening, I mean, when you do a screening testing for everyone, for example, going to school, what is the percentage of false results in this?
Yeah, it depends on the test that is being used. A problem with the antigen test, if you use it for screening, it is possible, but that depends on the test. These tests are considered to have a 60 to 80% accuracy, meaning or sensitivity, I should say. For each 100 people that are infected, it may be positive in 60 to 80%. So you will be missing anywhere from 20 to 40% of those who are infected, especially if the amount of virus they carry in the nose is small. That's for false negatives. For false positive, these tests can cross-react or give positive results on people that may have been exposed to other coronavirus, for example. So they will give maybe a false positive rate, depends on the test, but let's say 20%. That's quite high, especially when you have very little disease, you're screening and you're detecting this much false positive, you're diagnosing as possible COVID a lot of people that may not have it. So it does have its issue. It depends on the higher the level of disease in the community, then the less false positive results you may
So
get by
do
screening.
you think if someone get tested for the virus and it came out positive, do you think it should be redone in 2 or 3 days later, or no? It's not necessary. It might be false, for example, as a positive false. I mean.
Yes, it may be false. So things are recommended if it's available is to repeat a PCR. So if you do the antigen test and it's negative, but you're highly suspecting the disease, follow it up with a better test, a PCR. If you get a false positive and you don't think the person really has a disease, you can confirm that test with a PCR. So the PCR being a better test could be used if available as a follow-up.
And when should a person get tested if, if someone is exposed to the virus and or he have seen a positive person, how long should he wait to get tested after?
Yeah, that is a question for which we don't have the answer. Ideally, you can test every day because after exposure, the person can develop symptoms anywhere from 2 to 14 days. So which day then to test? You can test at day 3, but if that's negative, that doesn't mean that they can become positive at day 5 or 7 or 10. So we usually, when we do it here in the hospital, we recommend anywhere from day 5 to day 7, ideally, because we don't have the capacity to test daily. No matter what result, if you get a negative result, the person still needs to stay in quarantine. So the only advantage of testing somebody that is exposed is detecting if they're positive earlier. But if they're negative, they still have to complete the full 14-day quarantine period because that person can become positive at day 13 or 14 for that matter.
Okay. And is it true that after the 10th day, after you are infected by the virus, you cannot spread it anymore after the 10th day, or you should wait till the 14th day? 2 weeks, I mean.
Yeah, we're talking about two different things here. For the person that is exposed, they have up to 14 days to become symptomatic and show signs of the disease. That's the incubation period of the disease.
Okay.
2 to 14 days. So they have to complete the 14 days. Now, once a person is infected and they have the virus, if the disease is mild to moderate, they were not too sick, after 10 days, they don't excrete any more infectious virus.
Okay.
So in those, it's up to 10 days. If the person that is infected was very, very ill with bad pneumonia in the unit or is immune suppressed, those people tend to shed virus for a little bit longer. And in those, the recommendation is to stay on isolation up to 20 days.
Okay, so a person should remain isolated because we know that some people after getting infected, after 2-3 weeks, they are still showing a positive result after
Yes.
a PCR. So do you think they should remain isolated, or they can go out in public after?
Yeah, they can go out.
Ah, they can.
They can certainly go out after 10 days. For most people that stay at home, that they have disease, that they were able to stay at home because they were not very ill and they didn't need to go to the hospital. For most of them, 10 days is the recommended isolation period. That's what the CDC, Centers for Disease Control, recommend. And there's no reason to retest. We don't do it anymore. You completed your 10 days since onset of illness, more than 24 hours without a fever, an improvement of symptoms, they can stop. These people can stop isolation.
Okay.
And no reason to retest.
And doctor, can the COVID-19 test tell us the difference between someone who has an active infection or someone who was previously infected and he has no more the virus?
For the antigen, for the PCR or the nucleic antigen test and nucleic acid test, as I said, once the most important parameter is symptoms, once you're done with the symptoms after 10 days, then after that, the presence of detection of the particles doesn't tell us that the person is still ill or transmitting disease. For question is harder for the people that never had symptoms, because if you never had symptoms, we don't know when you start the count. So what we do is that for asymptomatic people, if you do the test and you're positive, then we do 10 days of isolation since the first positive test. But these people can continue shedding the virus for 3, 4, 5, and 6 weeks. Now, the antibody test can tell us if the person, let's say, as is being used, you were never ill, or you may have had an illness a month ago that you were not tested. If I do an antibody test, one of the more reliable ones, and that shows that you have antibodies against COVID-19, then that would be an indicator that you likely were exposed to the virus in the past. So antigen or PCR tell us that the infection is more recent in most people. Antibodies can tell us if a person was infected in the past. Antibody tests should not be used to diagnose while the acute illness within the first 2 weeks. Does that answer your question?
Yes, great. And what about the immunity after the virus? I mean, for example, if a person got the virus and he was cured after 2-3 weeks, do we know for how long he's immune to the virus later on? Is it already proven, I mean?
Yeah, that's another question that we don't know. We will know more once we observe what happens with all the people that have been infected if they get reinfected. Mm-hmm. What we know now is that people that they're the sickest are more likely to develop antibodies and higher level. Mm-hmm. If the person was asymptomatic, they tend to have lower antibody levels. That's a trend. After 1 month, antibody levels start coming down, and they really come down. Now, what most recent studies have shown is that we get also a different type of antibodies are more durable, and we also get T-cell responses are also more durable and can protect the person when they get re-exposed to the virus. So right now we know that at least for the first 3 months, we think disease will not repeat. We don't know if it will repeat later. As for everything else, the immune response has to do with the host, the person. So the older person tends to have lower antibody levels, so they may be more at risk for reinfection later on. The immune compromised people with other underlying diseases. Reinfection at this point has been documented in a couple of case reports, but the thought is that it's going to be a rare phenomenon to happen in the first few months after the illness. But really, we don't know for how long the protection will last. With other coronaviruses, lasts between a year or 2. So that's the hope, that it really will remain at least for a couple of years.
So do you advise,
natural infection.
So do you advise a person that got already the virus to stay to pay attention later, and he should wear a mask and be protected as usual, or because some people when they got over the virus, they go out and they think they are completely immune to the virus. So this is a misunderstanding, I think between people.
I think it's a misunderstanding because not all antibodies are the same, and the antibodies are important are the so-called neutralizing antibodies. So are the ones that actually bind to the virus and will prevent the infection of cells in the person. And those are not measured by most tests. So you have the antibodies or not, but you don't know if by most tests the level, and you don't know the quality. You don't know if these are the protective ones. So we don't know which people develop protective antibodies and for how long those will last. So I strongly recommend, and that's a general recommendation, even if you were infected, you should continue to follow all precautions and use masks and do the distancing when you're with others. People should not think they are protected because we don't know for sure for what level of protection people will have and for how long the protection may last.
So tell us more about false negatives. Is it a problem and why? Because we know that there's a very high percentage of false negatives. You were saying that probably between 20 or 30%.
Yeah, again, depends on the test. At least the one thing is that we don't have what we call the gold standard. So we don't know to what are we comparing our tests. But example for the PCR testing, we think will detect 90% of the infection. That still leaves us at 10% it will not be detected. The test itself is very good. The PCR is an excellent test. You will have very little virus there and it will be detected. But remember that we also depend on when the sample was taken as in the duration of the illness. These test levels tend to be higher in the NAIRS in the first 7 to 10 days, let's say from day 3, 5 to day 7, 10. So that's one. If you get it later on, then you may not find the virus in the NAIRS, in the nose. The other one is the sampling. We're all human beings and we're depending on somebody taking this sample. We have the nasopharyngeal sample that has to go deep in the nose, and we have NAIRS samples. The nasopharyngeal is generally better, but it has to be done well. And most people really do not tolerate it very easily. If you have had it done, you know when it's done right. You really feel that little swab going very deep in your nose.
Yeah.
In the NAIRS is a little bit less. So that's another reason for false negatives. It's not that the test doesn't work, it's that the sample may not have been the best sample that was collected. So it's the timing on when the test is obtained, it's the quality of the sample. Now we have saliva samples that remove that technique. You just spit in a cup, and the amount of virus that has been found in saliva by PCR is similar to that is found with a nasopharyngeal swab. So that would make it easier to take tests and in a way maybe more reliable and as reliable and consistent. So the problem with false negatives is that you get a test, you have a person that looks like they have COVID and your test is negative. We continue to manage those persons as if they had COVID because we have to assume they have it and the test may or may not have worked. The other tests like what we have here, the ID now is a different modality. Is a little bit less sensitive. That is estimated to be anywhere from 60 to 80% compared to PCR, and the antigen test similarly. For example, for the flu, the test detects the disease in about 60% of the people that have it. Well, it's behaving the same with COVID. Maybe 60 to 70%, we just don't know. Remember, many of these tests are being approved very quickly by the emergency use authorization by the FDA. So they have not been tested as rigorously as tests in the past when they get the full approval. So there's a lot of tests for antigen tests, it's just one that has been, or a couple that have been approved. For antibody tests, there's quite a bit out there that we don't know really about their quality.
So now we know that also the kids, students are going back to school. We have the back to school season. So what are your advice? Should they still study online or physical? They can go physically to school. What is your opinion on this?
You know, this is very hard. I really think that kids do better in school. There's no question about it. The question is to do it safely.
Yeah.
So if kids in the school can be kept in small groups, that they don't mix with each other, and within the group, they can keep the distance with the teachers and between them. If they can use the mask and distancing, being outdoors. So outdoors is better than indoors. Some schools in New York are testing the outdoor modality. Mm-hmm. The more you distance yourself, the better. So it's at least 6 feet, but no question about it. 9 is better than 6 and 12 is better than 6. So the distancing, outdoors versus indoors, and wearing the mask. If you can, and the washing the hands, if those things can be enforced at least, and the more they can be done instead of 190% of the time versus 10% of the time. If all these things can follow, I think potentially kids could go to school, but then all of the measures really need to be in place.
And do you think they should get tested before going to school, or and which which age is better to get tested? I mean, the small ones under 6, maybe they shouldn't get tested. Above 6, or it's irrelevant.
Yeah, that all kids, even although they don't get as ill as frequently, they do carry the virus. We thought that they don't transmit it as much. There's different studies that have shown that the little ones shed it as much as adults, or they shed it a little bit less, but those between 8 and 18 shed it as much as adults. Now, you can test when they go to school, and that gives you a one-time picture. So yes, it's good because on that first day, you can right away send away those that may be positive. But unless you continue the testing on a regular basis, then you don't know what happens after that. So if it were to be available, a test that is perfect and you can do very quickly and you have the result in 15 minutes, that would be probably the best approach. And that is where some people are promoting, you know, the frequent testing. Even if your test is not perfect, frequent testing may overcome the fact that the test is not as good.
So where are we from treatments today? Is there any unified protocol in treating COVID-19, or it's still depending on each case alone?
Yeah, in the hospital, you mean in the hospital really pretty much the approved protocols or considered standard of care at this time is the use of remdesivir, which is now approved to be used in people that are hospitalized regarding of their oxygenation levels, and that dexamethasone, which really is an intervention that showed very clearly that prevents progression of disease and prevents mortality. So those are across the board. Other modalities, we have the convalescent plasma that was approved also for emergency use authorization. That data still is not final. There's no randomized clinical trials. We know that when it was used, it appears to be safe. I think that we can say. How effective it is at the end, that part is not very clear. It seems to work, but this was not a comparative study, and we don't know that for certain. So studies are ongoing. And there are many other, you know, studies or agents or interventions that are under investigation, including monoclonal antibodies.
And for the mild cases at home, if you have mild symptoms and you are staying home, what are the procedure someone should follow, or certain medicines a person should take at home?
Yeah, really at home is symptomatic treatment. It really is your medication for body aches or for the fever, your acetaminophen or non-steroidals, either one is good. If the persons are on other meds because they have them for their underlying diseases, they should not stop. So if the person is taking aspirin because they're on aspirin for other indications, if they're taking a statin for the lipids, if they're taking an ACE inhibitor for their blood pressure, they should continue those. If they're taking inhaled steroids or they're taking steroids for any other reason, they should continue them. However, there's no indication to start them just to treat COVID. So statin shouldn't be started for COVID, or aspirin at home. There's no need to start it just for COVID, or the steroids at home are not really indicated. The one thing that we know about the studies on steroids is that they work in the sicker person with low oxygen levels, but in the less sick person in the hospital actually may have been deleterious and had adverse effects. So it really shouldn't be used with mild disease.
So, Doctor, how far are we from getting a vaccine, and what do you think is going on with all the vaccines all over the world? So, are we any near a vaccine soon?
I do think so. I mean, there are many different vaccines are in phase 3 trials with very large study populations, many of them being studied in 30,000 people and more, and they're placebo controlled, meaning people get the vaccine and some others do not get the vaccine. So that way we can test if these are protective against infection. That is really the bottom line, to know if you're protected, not if you have antibodies, if they protect you of getting disease. The vaccines that were approved in Russia, and also a vaccine that is approved in China, they have the same modality also as two of the vaccines are being studied here in the United States, which is the AstraZeneca and the one from the University of Oxford is the same modality. That's from the British government. They use a vector, which is the adenovirus. It's a virus where the COVID-19 or the coronavirus particles, genetic particles are injected, and then they get replicated in the body and antibodies get produced. This is a methodology or technology that has been used before with other vaccines. Seems to have good antibody levels. We should have results of those soon, but how soon is soon? Maybe I call soon end of the year. That is my soon. Maybe by the end of the year. With a Moderna vaccine that uses a different technology, that's the other one that is being tested, that uses RNA that is injected in the virus RNA that is injected as part of the vaccine. That again is enrolling about 30,000 people, and we should have results of that by the end of the year. So I do think by the end of the year, we should have results of the ongoing studies.
And you think that all people should take the vaccine later, or are there any priorities?
Yeah, ideally, the vaccine will be distributed for everyone. Production of vaccines is ongoing, even while the studies are being done. So by the time the studies are done and we have the results, the production is already there. But of course, there's not enough for everyone. So which are the groups? I do think that the people that are more likely to be exposed should have priority. Of course, I may be biased on that, but I do think healthcare workers and first line responders, those that are risk to be exposed because of the nature of their work. And also the more vulnerable, nursing home residents that have shown to be so vulnerable to the disease in their environment should also be given priority. So how it is then phased into to cover the full population, that's going to be a logistic issue that I will leave to the public health to, authorities to decide. But there's going to need to be a little bit of a phase-in. We cannot in one day vaccinate the whole population.
So we heard about a second wave. We hear every day there will be a second wave. And I think we are still in the first wave. I don't know. So what do you think, where do you think we are? And do you think maybe the virus, for example, is getting weaker and can be vanished by itself all alone, like it happened with the Spanish flu back?
Yeah, I don't think it will vanish by itself. Spanish flu circulated for 2 years. And they killed quite a bit of people. I don't think it's going to vanish by itself. It will vanish when we have enough herd immunity. That is, enough people are immune in the community that they can block the continuation of transmission of disease in the community. The calculation is that you need at least 60% of your population to be immune to be able to cut transmission in that population. I don't think we can achieve that amount of immunity by disease. It can be achieved, but at the cost of a lot of people getting sick and possibly dying. So that's not a very good way of achieving herd immunity. And the only way of doing it is then with immunization. Eventually we will get it. We want to get it via immunization. We don't want to get there via everybody getting sick. And all there are many complications of COVID-19. Let me just say that we don't know about. So it's not just getting the disease. Many people get it and they're over it and they're done. But many other people are left with sequela that go for weeks and even months that we know for now. So because we don't know about all the complications, we really don't want to just allow everybody to get sick and then be dealing with all this down the road. For as long as we continue to try to prevent transmission, then we will delay the completion of the disease going throughout. That is one way of doing it. If you really get the people that are less likely to get sicker, the younger, those without underlying disease, if they get infected and immune, then they may protect the older. They may protect their parents and their grandparents from getting sick. If that can be achieved, that's what Sweden attempted to do. They were not as successful as they thought they were going to be. They do have a high mortality, higher than the other Scandinavian countries. So it's in how long we can achieve it, I just really don't know. 2-3 years without a vaccine. We may have bouts every year of disease like the flu that will hit or make sick the vulnerable people that are not immune. We just don't know. We don't know for how long the immunity would last. So in 3 years, we may have subsequent waves.
So
we don't know.
Are you optimistic about the future?
I don't know.
Are you optimistic about the future, and are we near? You don't think we are near the end of this pandemic yet?
No, we're not. We're not. When are we going to be near the? I think that if we have successful vaccines, and they can start to be administered early next year, maybe by the summer, maybe by the fall, maybe we will avoid a wave in the fall of winter of next year of 2021. So I'm optimistic that we will have successful vaccines, and I'm optimistic that these vaccines can reach most of the population and for most of the population to be protected. I think that we can achieve that within a year, possibly, and avoid a big wave for the next fall of 2021. So that's where my optimism goes. I still think we're going to need to continue to be very careful through May, June next year for sure.
So, Doctor, do you advise people? We know we are now. We're going to start with the autumn fall season. So, do you advise people to take the flu vaccine? All people. We know that not most. Most of the people don't. So, do you advise people to take the flu vaccine, not to get? They have the same symptoms. The COVID-19. Approximately the same symptoms. So do you advise people to take the flu vaccine, not to mix between the two viruses?
Yeah, absolutely. Everybody should get all the vaccines they're eligible for, children or adults. And everybody should be getting the flu vaccine this year. It's already available. We don't have much flu though. That's a good thing, because as we trying to prevent COVID, we're also preventing flu transmission. So we had, at least in Houston, no flu really circulating yet. But that doesn't mean that it will not start circulating later in the fall as it does every year. So maybe October, November, December. So yes, everybody should get their flu shot. All ages, older than 6 months to 90s.
Okay, great. So would you like to add anything, Doctor? Any advice to people tested positive, what they should do to avoid spreading the virus to other people?
Yeah, people need to continue to use the preventive measures. They need to work on their bubbles. So they need to continue to use masks and keep distancing. And they shouldn't be mixing bubbles. So where you are a household, family, you're all protected, you can then relax your measures. But when you meet others that you don't know how much prevention they're following, then you should use protection with others that you're not sure what they're doing. So when you need to keep small mixing. You cannot be mixing with 10, 20 different households at one time. If you're going to be mixing, it has to be with small groups, and you need to always ask what others are doing. We cannot assume people are being careful. You need to ask, what are you doing? Where are you going? Are you using your mask? Are you keep distancing? If you have those questions and they're doing it, then you can get together in the same, in your little party thing, keeping distancing when you're eating, when you're removing your mask. I'm going to give you just as an example. I have my 89-year-old mother at home. I keep distance with her. I use my mask. That's the only way I can protect her.
Yeah.
Because I am the one that is going out the house. So that's what I recommend to others as well. You need to protect the most vulnerable in your household and in your community.
And one more last question. Do you think the healthcare sector is better now prepared than it was before? And do you think we might go back to lockdowns maybe anytime soon, or we won't be needing lockdowns or confinement again?
I hope and I think we will not need lockdowns. I do think that if everybody used the preventive measures that we know work, that using the mask and keep distancing, transmission really comes down. I can tell you in Houston, we have the big spike in July as a consequence of everybody going out and not following precautions. Everybody started following them. You had to go to the store, you had to use your mask. We saw the amount of disease coming down. We know it works. We just need to keep doing it. We cannot relax and think everything is good. We need to keep doing it, and possibly through April, May, June next year until we have the vaccine. That's my recommendation. People need to continue to be careful.
Okay, thank you, doctor, for your time. It was a great interview, and thank you for the information you gave us. And hopefully we'll get over this virus altogether very soon.
Yes, thanks to you.
Thank
and
you.
stay safe. Thank you.
Yeah, you too. Thank you.
Thank you.